Good morning, everyone. Thank you for joining me. It's a Monday morning, and I'm sure a lot of you are taking the time out of your busy schedules. It is appreciated. It's a funny time we're in. I know a lot of you are trying to get back into the workflow. So again, spending a little bit of time with me is great. And today we're going to be looking at an overview of tooth whitening, as you know. So for those that don't know me, my name's Adam Toft. I have worked alongside Paul since about 2010. So I'm one of the senior lecturers, demonstrators and tutors on the courses with Tipton Training, but also I'm part of BARD, the British Academy of Restorative Dentistry. Just a little bit about me. I qualified back in 1995, so I've been at it quite a long time. Still enjoy my dentistry, and much like many of you guys, I've been quite frustrated over the past few months about not being able to do the dentistry that we want to do and that our patients need us to do. Overview of tooth whitening. Let's have a little look at that for us. Okay, so the main idea today is just to go through a little bit about the topic itself, not to go into too much detail. I don't want to send you to sleep on a Monday morning. For those of you that managed to watch Linda Greenwell last week, she covered a lot of techniques about whitening in more detail. So there's going to be a little bit of overlap, so I apologise if you've watched both, but hopefully that will just help cement the knowledge that you need to go forward with your patients. So we're going to look a little bit about the history, the role and the process of tooth whitening, try and dispel any myths that might surround it, and put you in a position whereby if your patients ask any questions, you're in a position to answer with confidence, all right? I'm a great believer that patients aren't daft. If you can talk about a subject with knowledge and a little bit of passion and enthusiasm, they're much more likely to buy into what you're discussing and talking about. So having the answers to the questions that they may pose is always a good starting place. Okay, guys, so I don't know whether many of you recognise this. I know I've got some delegates listening from the UK, but also from Dubai and possibly Nigeria as well. So for those of you that don't know, this is the Crooked Spire in Chesterfield. So that's about the only thing that Chesterfield is famous for, and that's where I practice. I've been working there since about 1995. So again, predominantly wet finger dentistry for most of that 25 years. And now work predominantly on a private basis. So 2 to 3 days in practice, and then 2 to 3 days teaching in Tipton Training. So I have a really nice balance, and I feel very grateful for that. It keeps me interested and keeps me going. Okay, I just thought I'd start with a little bit of fun. I hope you don't mind. It's a little video clip, and with it being a Monday morning, I know Louis said it was sunny in Manchester, but where I am it's quite foggy and misty. I just thought a little bit of fun and a little bit of lightness to start the day, so I'd just like you to have a little look at this for me for just one moment.
Hey guys. Hey, what's up?
Okay guys, sorry, just a bit of humour. I did like that this morning. I think the scary thing from that is that I was actually back in 1999, so that's 21 years ago. And I think the importance of that is just to let you know that patients out there know about whitening. It's not something we have to be particularly selling. A lot of patients will ask you for that treatment. Whether we like it or not, it's in the press, it's in the news, it's in the glossy magazines. Everyone is now conscious about their teeth and how they look. So again, it's a great intro for us just to start the conversation with them. Okay, so this is what we're going to be covering today. It seems like quite a long list. Don't worry, we're not going to be spending ages on each one. Some are quite short, some of those are a little bit longer, but it's to give you that overall sense of what we're doing and the understanding that you can then take on to your patients. Okay, so why bleaching? When Paul asked me to do a lecture on whitening, initially I thought, well, hang on a minute, everyone's whitening. Why do we need to do whitening lecture and stuff? And it's, as I said earlier, it's to give you a little bit more understanding, I think, hopefully behind those things we talked about, so that again, it puts you in a position where it's easy to talk to your patients confidently and fluently. Okay, I presume everyone is whitening. I would hope so. There's no reason not to, and as you see as we go through, as we dispel some of the myths, there's absolutely no reason we shouldn't all be whitening our patients' teeth. Just as an aside, given all the COVID scares and the non-aerosol generation procedures and stuff, this is one technique that you can actually safely do. So I'm not saying you should rush back to work and dive in and whiten everyone's teeth. We need to get the emergency sorted out, get our patients out of pain, but it is something that is an easy way to get back into the dentistry side of things. Okay, so we know from publicity, from the celebrities out there, that they all want nice white teeth. And if we look at some of the research, 80% of the population tend to be unhappy with the colour of the teeth. And bleaching is simply a series of steps that improves the patient's appearance. All right, give them a more attractive smile, hopefully a little bit more confidence as well. Any of you that listen to Paul and his aesthetic course that he talks about, he always says how a beautiful smile and white teeth is associated with health, beauty, success and happiness. So we know that doing some whitening, doing some of the aesthetic work that we do can make a huge impact on that patient's life, give them a lot more confidence going forward. It's one of those really nice treatments that is non-invasive. You know, you can do this to someone without picking up a drill, yeah, without having to do any discomfort, any injections, and you can make a real difference. And it's a great practice builder, a really, really good practice builder. Okay, so let's first of all look at the history of bleaching. So guys, when did bleaching, as we first know it, arise? Okay, so you'll probably find I ask you questions. I'm much more into face-to-face teaching, so I find the talking to a computer screen quite difficult, so bear with me. So I will throw some questions out there just so you can start to mull things over. And obviously at the end, we'll go through any questions and answers. So please feel free to write those down and we'll come back to those at the end of the webinar. Okay, so it was actually an accidental finding. There was an orthodontist called Bismir who used to put carbamide peroxide in his retainers for his orthodontic patients, those that were having gingival irritation and problems like that. And he found that it helped reduce the gingival irritation, but it also lightened the colour of the teeth. Okay, so that's bleaching as we know it, how it first started. All right, there are reports back that the Romans used to do it as well, and things like that. But bleaching as we know it, back in 1968. And then this guy, Van Haywood, pictured on the right-hand side there, is the person who, again, alongside Heyman, started doing research into this. Okay, and night guard vital bleaching, which I would say is our mainstay of treatment, something that is my go-to one for tooth whitening, was first introduced properly in 1989. Okay, now Van Haywood has been doing this now for 30 odd years. I listened to him in the early 2000s and he was still passionate and enthusiastic about his tooth whitening. I would advise all of you, if you get 5 or 10 minutes, is to visit his website, which is vanhaywood.com. There's loads and loads of resources on there. Most of the information and some of the papers I've got have come from that website. So please go on there. There's consent forms, there's information sheets, patient questionnaires, all sorts of information that it would be useful to have a read through. So please feel free to go and view that and have a look. While I'm at it, the other person, as I mentioned earlier, Linda Greenwald, who was on last week before us, she's got her own website, again, lots of information and valuable papers on there. So important to keep reading up on the topic and seeing how things change. Okay, that was quick, wasn't it? It's the history of bleaching. So, nice to be able to tell your patient's been around a long time, I think, and that we've been using it in the same format for such a long time. Okay, so that's the history of bleaching. Safety of bleaching, simple question, is bleaching safe? And it has a simple answer. This simple answer is yes. Okay, and we'll look at why. Okay. From the research and the papers out there, there's little concern regarding the consumption of tray bleach, and that's one of the worries. We know from studies that the liver produces peroxide naturally, and the amount that is in a tray that you might possibly get into your mouth is much, much less. Within our saliva, we have natural peroxidases that break down any of that occurring hydrogen peroxide. So given the small amount we use, absolutely no concerns at all with the use of that. So again, it's good to be able to tell your patients. Patients will worry. Some patients will come in and have a load of questions to ask, and it's good to have those answers right in reach. Okay, so again, we found that from research that normal tooth whitening will not cause subsequent need for root canal treatment. There's no internal or external resorption. Now that is with this non-night vital guarding bleaching. If you're doing inside-outside bleaching or you're doing internal bleaching, then that can be more of an issue. But with the tray bleaching systems that we're using, it really isn't a problem. Okay. Sensitivity outside normal limits. Some patients will suffer from sensitivity, and we're going to talk a lot more about that shortly. Okay. And the last one is no detrimental effect to the tooth. So all positive news for us and our patients. Again, Niels Correct did a good study, and he said that there's no problem with long-term hardness or roughness of the surface. It maintains it's the same, all right? So it's safe to enamel. Okay. One of the people's major concerns is the process of how it bleaches and the formation of oxygen-free radicals and the possible link to cancers. Well, both the American Dental Association and WHO have all stated that because of the low concentrations that we're using, there's no risk or no concern about the hydrogen peroxide causing cancer. Okay. As I say, it's been used since the late 80s and there's been no problems, nothing to show that there's been an increase due to the use of this technique. I just mentioned here a little bit about bleachorexia, all right? These are the patients who come in who teeth just are never white enough, they want more. And I'm sure we've had some of those patients who turn up every Monday morning, knocking on the door, say, oh, can I have another tube of tooth whitening gel? Can I have another tooth whitening gel? And they do it on a regular basis. We have to be wary of those patients, all right? We might never meet their expectations. And it's important that we realise and can tell those patients early on in our treatment. And that's all part of the history taking, talking to our patients and getting to know them, okay? In fact, it's an important point to remember, if a patient is coming back and wanting a new syringe of the gel, it really is a new course of treatment. Things can have changed, so it's 3 or 4 months. So really we should be seeing the patient and re-examining the patient, and we'll see why later. Things can change, and then if we do whitening and it causes a problem and we haven't checked, then obviously we're at fault. So don't be scared to say to the patient, yes, you can have another tube, but let's get you in, have a consultation and just make sure there are no changes. Okay, so what's the legal status? Okay, now, a lot of the listeners on today are from the UK and Europe, that's fine, but I know I've got some Dubai delegates listening, as I said earlier, and that will be different. I know that in Dubai, the solutions that are available are much stronger. I don't think that's particularly an advantage, if I'm honest, but from the UK point of view, the new legal standings came up in about 2012, so we need to be aware of those, all right? And in fact, it's sort of clarified what we can and can't do much better, okay? So the General Dental Council are out there to protect the public, and we know they do that very well. Sometimes, unfortunately, they look after them more than us, which is a bit of a shame, but we won't go into that. It's important that, as dentists, that it's us that are doing the whitening, not beauticians, not people outside Tesco's doing, laser whitening for £99. And there's a lot of reasons for that, and we'll talk about that in a moment. We're the ones who diagnose the problem, look at suitability, look at potential problems. Is there any caries or the crowns? Is there any apical pathology, etc.? So we need to be aware of that, and that's why it's as dentists that we should be doing this treatment. We'll talk a little bit about hygiene therapists and hygienists, because under prescription for the dentist, they also can do the treatments, but we'll talk towards that towards the end. Okay, again, the Council of European Dentists, much the same. All right, they want the dentist to be doing it. Okay, and that's because we can look at the cause of the discoloration. Okay, we can look at how well it will work, give the patient an idea of whether it will be successful or not, and we can look for any other oral health problems and not miss anything that we might need to see. Okay, there are often lots of ways of treating a patient, and tooth whitening is obviously one of them, but it might not be appropriate for everyone. Obviously, as a dentist, we can then discuss those problems with the patient. Okay, so a lot to read on there. I mean, the take-home message basically from this is 0.1%, anything underneath is the only product you can get that can be sold over the counter. As dentists, we're allowed to use 0.1 to 6% hydrogen peroxide. Okay, the important bit here, which I've underlined, is the dentist must do the first application before the patient can administer it at home. Okay, so you must show them how to load the trays. You must seat the trays into the patient's mouth. Demonstrate that to them, that's part of it, okay? And the other slightly contentious issue which has changed, we're not allowed now to do it on patients aged under 18. Now, it used to be 14, and they've changed that to 18. I think this is a shame, and I think from what I heard from Linda Greenwell last week, that there's a big push to change this age limit. If you've got a patient who is changing school or is young and is getting bullied and picked on just because of mottling and whitening of the teeth, I think we should be in a position to treat those, and I think we're doing them a disservice if we don't. So hopefully that will change, so keep your eyes out for that slight change in the laws. Okay, so as I say, up to 6% in the UK and Europe. I'm totally aware in Dubai that they can use up to 35% some of the kits contain, which is much, much stronger. And again, from my point of view, and what you'll see as we go through this, I'm not always convinced that it's a huge improvement using a a stronger solution. We'll look at why in a minute. Okay. So under the supervision of a dentist or dental care professional, and again, that's really important. You know, if a patient comes into you and says, why can I have my teeth whitened for £99 down the road? Yeah, what do you say? Well, you know, you've got to be proud of the fact that you're a dentist, you're working in a proper dental clean environment. You've all had CRB checks, you understand the process, you're immunised, you know, we've got all GDPR now, we're aware of problems that might arise during the treatment. There's a whole host of things that you can tell your patient as to why you're more expensive. And we shouldn't really be cutting the price just to match whoever's doing it down the road. Sometimes I think actually we have a set price and we don't vary it enough. And part of us as dentists to look at that whitening case, categorise it. Is it easy? Is it going to be a bit more difficult? Is it going to be really hard? And then we can look at varying our prices to correspond to the amount of time and length of time that that treatment might take. Okay, so how does bleaching work? How do we tell our patients if they ask what the process is? I know I went into one of these local stores and asked to have my teeth laser whitened, as it were, and just being, you know, like myself, I was saying, so is it a real laser? And she said, well, it's not a real laser. I said, oh, right, because you said it's laser in the window. No, it's just blue light. I said, all right, well, that's fine. I said, and what solution do you put on the teeth? And they said, oh, it's a secret solution. We can't tell anyone. And I was like, well, you're putting it in my mouth. What is it? So for me, that is just no good at all. Yeah, we need to be totally transparent with what we're using, how we're doing it, and be in a position to be the best and safest for our patients. But we need to know how it works a little bit. Okay, so we need to be aware of the different sorts of staining that's present and how we're going to tackle that. All right, so the reasons can be that extrinsic, intrinsic, and age-related, as you can see. So intrinsic might well be things like food and drinks, smoking, that sort of thing. All right, that's on the outer surface of your teeth. The other thing is intrinsic, so that can be inside the teeth. So it might be slight loss of vitality, some liver and kidney disease can cause discoloration to teeth, antibiotics, etc. from the past. Okay, so having an understanding of the different sorts of discoloration available and understanding which treat or treatable better than others is a great way to go. Just a little case here for an Enlighten Evolution case there from the Enlighten guys. What a difference is that? You know, to me, that's just amazing. We haven't numbed the patient up, we haven't drilled the patient's teeth, and we've taken someone with quite severe staining here, and we've really managed to change the teeth colour here. Now, to me, you've really done a service for that patient. Okay, for me, that is a great start, and it's going to build great rapport with the patient, and it's going to get you more patients in without even thinking about it. All right. Now, unfortunately, I know some people in some places in the world, and again, I've done some seminars and lectures in Dubai, and a lot of people would even consider veneering these teeth. Now, to me, that is just overkill. You know, if this was my son or my daughter, there's no way I would have wanted to take a drill to those teeth to veneer them. Yes, you could bring out the buccal corridors. Yes, you could change the shape. But for me, whitening is more than enough for this patient. And I hope you'd agree with that. Okay, so the actual mechanisms of bleaching, the exact mechanisms aren't actually known, all right? But it's an oxidation reaction that happens, all right? So your hydrogen peroxide breaks down to oxygen-free radicals and a peroxyl-free radical, all right? And these then penetrate the tooth and slowly blast and dissolve the staining away. It's important to understand that the tooth acts a bit like a semi-permeable membrane. It allows the solution to pass straight in and through the tooth, all right? It actually gets into the nerve, through the enamel and the dentin to the nerve within 5 to 15 minutes. That's really quick, all right? And that's really important to be aware of. So you can get sensitivity quite quickly, all right? Both the enamel and the dentine chain, it tends to be mainly the dentine, obviously if it's intrinsic staining, and it works nice and straightforward. As I say, you don't need to know too much, just so that you know the basics behind that. A few little things you do need to know. A tooth has a certain saturation point, all right? And there comes a point where you've whitened a tooth to its maximum, and no matter how much more you try and do, it's not going to get any whiter, all right? So again, be aware of that, and be aware of those patients who want more whitening, more solution, okay? A tooth has a maximum rate of whitening. They will basically change colour at the rate they want to. Everyone will be slightly different, but they will only change at a certain rate for that person. And just because you use a higher solution or concentration doesn't mean it will happen quicker. So using maybe a 20% carbon peroxide isn't going to be twice as quick as a 10%. Okay, so there might be a slight discrepancy in changing it, but it'll end up being much the same, and you end up at the same endpoint. Okay, so just bear that in mind when people are sometimes reaching for the stronger solution. You're going to get to the same endpoint, and with a stronger solution, there's more chance of sensitivity and problems with that. Okay. Materials. Okay. So two main ones that we use, you're well aware of this, hydrogen peroxide and carbamide peroxide. My personal go-to is carbamide peroxide. I very occasionally use hydrogen peroxide, but I prefer the latter for nighttime whitening. I just feel it works better, it's more predictable, and there's less sensitivity associated with it. And all that carbamide peroxide is a combination of hydrogen peroxide and urea. All right, just little things to bear in mind is 6% hydrogen peroxide is very similar in concentration to a 16% carbamide peroxide. So in the UK, we're looking at a maximum of 16%. As I say, elsewhere, it might be more than that. All I would suggest if you are working elsewhere is to check with the manufacturer what percentage you're using so that you know when you're discussing with the patient and when you're writing your notes up. Okay. Hydrogen peroxide has its uses. Okay, and I occasionally use this during daytime. It doesn't work for as long, it's much quicker. So if you've got a patient who's struggling to wear the trays overnight, then wearing them during the day, just for 30 minutes in the morning and the evening, might be more tolerable. But again, it's not my go-to treatment solution. I much prefer the night time. Okay. A little bit more chemistry for you. I think that's probably more than enough at this time of day. So your carbamide peroxide splits into hydrogen peroxide and urea and then breaks off, and you get your oxygen-free radicals that do the whitening in the tooth. Is that enough chemistry? I think so. Okay, so if you take a look at this graph, and it's nothing to do with COVID and curves and leveling off and things like that. It's to do with the hydrogen peroxide, carbamide peroxide, and how long they work for. So if you look at the green line, the hydrogen peroxide, okay, it works, and it's maximum very quickly within about 30 minutes, but within an hour, it's pretty much stopped working. All right, so again, as I say, potentially useful if you're doing short duration whitening during the day. If you look at this curve, this is why I prefer carbamide peroxide. It lasts and works for a lot longer. So it does most of its work within the first 2.5 hours, and then even the next 4 or 5 hours, it's still continuing to whiten. So what I will often say to my patients is, put them in at night time, wear them. If you wake up at 4 or 5 in the morning and go, I've had enough, and you want to take them out, you can do. They will have done what they wanted to do during the night time. Okay, so it's important to know the difference, the sort of the half-life of how long they last for. So just to reiterate that, carbamide peroxide lasts for 4 to 6 hours, and your hydrogen peroxide is literally 30-45 minutes, so it's not as longer acting. Okay, so that's why the carbamide peroxide is great for the nighttime whitening. Okay, so the addition of urea, which is an interesting factor to the hydrogen peroxide, actually raises the pH, all right? And again, this is something that is starting to be looked at more and more now, because it can have a therapeutic effect as well. And there's been some research, and they're looking at the role of tooth whitening and the bleaching gels in the control of caries in the elderly, root surface caries, patients who maybe have radiotherapy, or got dry mouth, etc. Then the bleach in there with the higher pH can actually help to inhibit and stop the progression of caries, and help as a preventative thing, method with the gums as well, if there's irritation available there as well. So, okay, so procedures. So what are the methods of whitening out there? And again, as dentists, we need to be aware of all the different methods so that we can have a proper conversation with our patients. So toothpaste. I'll ask you the question, do we think that whitening toothpaste work? Well, I don't think they do, if I'm honest. I think some of them are extremely expensive with very limited benefits. And most of the toothpaste and the way they work is they're quite abrasive. So someone who's using a whitening toothpaste regularly can actually cause a lot of wear to the teeth and the enamel. So it's not something I tend to recommend as a whole. I'd rather be doing it myself and doing it properly. Over-the-counter methods. So again, with the new regulations in Europe, these aren't readily available. Now, unfortunately, as you know, there's the internet. So people will buy things over the internet. The problem there is we don't know what they're getting. We don't know what website they're buying the materials from, and hence we don't know the safety of those materials. Okay? So again, it's worth having that conversation with the patient. Okay? Bleaching trays, this is the home bleaching that we're going to talk about and is our mainstay, I would suggest. We're going to look a little bit at in-surgery bleaching on Zoom. I have my own opinions on that, I'm sure you do, and we'll look at that in a little bit more detail. We're going to look at combination therapy, which is basically a tray system and an in-surgery system used together. Again, very successful system in light, and we'll talk about that. And then we're going to look a little bit about non-vital bleaching. We're going to look at walking bleaching, inside-outside bleaching. Okay. Now, again, just to reiterate, Linda Greenwell went into a lot of detail. She did a whole hour pretty much on this. So we're going to touch on it. If you want more information, I would urge you to go back and look at that webinar as well. So procedures. We've got a patient who's interested in whitening. What do we do? Well, examination is critical. We need to have a proper examination of the patient. We need a clinical history where we look at the medical history, the social history, the previous dental history. And also it's important to be aware of the patient's expectations. All right. Signs and symptoms. The big one for me is sensitivity. If a patient's got sensitivity when they come for a checkup and they're discussing whitening, I know that they're going to have sensitivity during the whitening. All right. And that means it's not always a problem, but it means we can start the management of that sensitivity early rather than waiting for it to get worse and then say, oh, right, we need to do something about that. So asking about sensitivity, yeah? Are they sensitive to sweet, hot, cold? Are there any occlusal problems there, you know, that cause sensitivity? So understanding that before we start the whitening will allow us then to be in a position to maybe look at treating that before we do the whitening. So maybe they've got some recession that we might need to put some GIC in. Maybe they've got occlusal wear, facets with dentin exposed that we might have to cover up first. So that's all part of the examination process. Okay. I think it's about 85% of patients suffer from sensitivity. When I first started a long, long time ago, I used to tell patients, you may or you may not suffer from sensitivity. Now I tell everyone they will, and hopefully it won't be as bad as it could be. But for a few patients, it's going to be difficult, and management of sensitivity is key. And there are ways to do that, and we'll look at that a little bit later on. While we're talking about sensitivity, I'll probably mention this again later, but the sensitivity tends to be worse on day 3, and this is when the maximum amount of oxygen is into the teeth. So if you can tell your patient beforehand that, yes, you might get some sensitivity, it'll be worse on day 3, and then it'll get slightly better. That's much better than getting a phone call from them saying, oh, my teeth are killing me, I can't cope, you never said it would be this bad. So pre-warn them, and then when they come back for the review, they'll often turn around and say, oh, it wasn't as bad as you said. Okay, so again, it's always planning ahead. I much prefer to under-promise and over-deliver with all my dentistry. That way you're setting yourself up for success rather than failure. Any special tests, radiographs, vitality tests are really important. We'll talk a little bit more about this when we look at the non-vital bleaching. The main reason this is important is if you've got a tooth that you're slightly suspect around, maybe it doesn't quite, you know, the colour doesn't quite match the others, maybe it's reflecting light slightly differently, I would always try and get a radiograph of that tooth. All right? Often you'll find a patient with a slight periapical area on an unroot filled tooth. Okay. Now the problem there is if you then put bleaching in or on that tooth, then you can cause a flare up of that tooth and pain, and then you may end up needing to do a root filling. So this needs to be seen before. You don't want to end up saying, oh, I'm really sorry, you know, I've caused that, which you haven't really, because it's just the whitening. They had an area before. But if you haven't got a radiograph to show that, then you really haven't got a leg to stand on, and you'll end up doing the root filling for nothing and all the hassle that comes with that. So vitality tests, teeth, radiographs of suspect teeth, just to make sure you're safe for going forward. So as we said, we've talked about the PA for discolored teeth. I know some dentists do radiographs for everyone, and I think that's a little bit overkill, and I'd be hard placed to justify that. But certainly for discolored teeth, I would always want a PA, and I'd also do a vitality test. Again, really, really important. We'll talk about photography later a little bit, but you must have pre-bleaching photographs. Okay, so with a shade tab in there, so you've got a record of your starting point. Really good to be able to do starting point and end point. Okay, great to be able to give to the patient. They can then see the difference. And also when they come back 6 months or a year later and see, oh, they've gone back to normal, the same colour there was when I started. If you've got a photograph with a shade tab in, you can say, actually, oh, they haven't, they've maybe gone half a shade. Another couple of nights, top up, you'll be back to where you were. So it just preempts it. It's good for you, good for the patient, but it's also good for your records. Just be aware as well with the sort of staining that you're trying to deal with. We all know that grey-brown tetracycline staining takes a lot longer. All right, and we need to know that. That's not going to happen in 2 to 3 weeks. That could take 3 months, 6 months, or 9 months. It's prolonged whitening for those sort of things. Okay, so we need to be aware of which teeth we think are going to whiten faster so that we can tell the patient. I always say that the kit I give you will be enough for 2 to 3 weeks. If you need more, we can then look at that time, but there will be additional cost for extra syringes of the carbon peroxide. Okay, so I like to arrange my shade guide in value order from the lightest to the darkest. I think it's just much easier putting that across the teeth and taking the photographs, then picking the shade that we are for starting points. All right. You can, as you know, get shade guides that go lighter than B1, and they're available. I've got those as well. All right, so have the shade guide ready, have your camera ready, and be ready to do that for me. Speaking to one of my colleagues, which I thought of this, which I thought was very good, he takes a shade of everyone's tooth at the examination. All right, and the reason he does that is it's starting for a talking point. They'll say, well, what are you doing? And they say, oh, we're just looking at what shade your teeth are. And he'll show them, and often they're not B1. And they go, oh, they're quite dark, aren't they? And they say, well, they are. They could be better. We could do some tooth whitening. So again, it's a nice introduction to bringing up tooth whitening. So that is a useful one to use, taking the shade of the teeth initially at examinations. The other time I always mention it is if I'm about to do a crown or some veneers for the patient. I'll always say, look, we're better off to whiten the teeth now. If you're thinking that you're going to want whiter teeth in the next year, 2 years, 5 years, it would be better to do the whitening now before we provide your crown so that we can shade match your crown to your nice white teeth. Okay, so there's lots of ways of mentioning it, but always try and get it into the conversation, certainly if you're going to start doing a crown or veneer. If you're doing multiple veneers, again, I would always want to do whitening before I did those, because the whiter the tooth is, then the thinner I can make my veneer, so the less preparation I'll need to do for that tooth. Okay, if they've got a dark tooth and you haven't whitened, you need more space. The technician has got room to put an opaque layer in to block out that colour. If we can whiten that underlying substructure first, we can get much more delicate, thinner veneers, which is much more minimal preparation for the patient. Okay, so where does whitening fit into the scheme of things for you? Well, I tend to do it fairly early on. All right, so basically after the checkup, it's the first thing I do before I do any restorative work on the tooth. I get the colour of the teeth right first. The only time I might change that is if I'm doing short-term ortho, in which case, as you've heard, everyone talks about align, bleach and bond. All right, so we align the teeth, we bleach them, and then we do the bonding. Okay, but otherwise try and do it early, because sometimes patients will come in with an idea that they want veneers. But by the time you've done the whitening, some of them might say, actually, they look loads better. I'll stick with that for now. I might do something further later. So again, it's a great way of building trust with your patients. Okay, so these are the procedures available. These are the ones we're going to talk about. Okay, we'll work through those in order. So let's start with the nighttime whitening. Okay, now this is the material I use, Zoom. There's lots of others out there, and there's Polar Day, there's Zoom, as I say, there's lots and lots to choose from on the market, and I'll be honest, they're all pretty similar. All right, I don't think there's any that's loads better than another. Find one that works well for you, one that you understand, the one that you find you're getting good results with. These are just some promotional slides from Philips and Zoom. Okay, they do a day one and a night one. The day one is 6% hydrogen peroxide. So again, you wear it half a minute in the morning, half an hour in the morning, sorry, and half an hour in the evening, and it takes up to 2 weeks. The nighttime one, which is the one I use, again, overnight. I tend to go for 10% because I think you get less sensitivity. And I find that with the Zoom, at least with the ACPs in there, it does help a little bit with sensitivity issues. And that's just a couple of slides of before and after. Okay, so these are the sort of trays I use, and we're going to talk about trays in a minute. It's important that you try them in and that they fit comfortably for the patient. They're not catching, they're not rubbing, they're not irritating the gingiva, because they can then sometimes confuse that with sensitivity from the gel, can actually be sensitivity from the trays themselves. So make sure they're fitted. Now I like to extend mine over onto the gingiva, all right, and I'll show you some slides from Enlighten earlier, explain why a little bit. And I ask my technician to to score around the next of the tooth. It makes like a super seal when it's sucked in. It helps hold the bleach, I believe, better. Okay. Again, part of the new legalities, as I said, you must demonstrate to the patient the loading and the fitting technique. So part of the process is obviously going through all the discussion with them, trying the trays in. I then load a couple of 3 teeth in the tray, and I'll get them to seat it in. So I'll explain clean your teeth at night as you would do normally, and then before you go to bed, you load your trays as such, and then place them in, and then I like the patient to actually press them against them to seal up against the teeth better. Okay, so that is part of the process. You can then write in your notes that you've shown and demonstrated how to fit and wear the trays. Okay. The studies and the research will tell you there's no difference between whether you have a reservoir or you do have a reservoir, all right? A lot of dentists will just go reservoir free because it's cheaper, it's easier, and it works. There is no difference really in it. I sometimes think you need to be a little bit aware of the bleach and the solution you're using. If you're using quite a viscous solution, then maybe reservoirs is better because it gives you a little bit more space to put that in. Okay. The other thing about having reservoirs, I think it takes a little bit of stress off the tooth itself. Okay, they're less tight. Sometimes you can bleach in retainers, which is absolutely fine, but they can be tight, and that tightness, a bit like an orthodontic appliance, can cause some discomfort as well. Okay, so again, with or without is your own personal preference. Certainly if you're doing a longer sort of bleaching, then having no reservoirs might be cheaper because you use less solution. Okay, and this is one of my cases from work. This is just 2 weeks of night whitening. This patient did the upper and the lower at the same time. Okay, sometimes I'll do just the upper first, and then after they've done those, I'll do the lower, all right? And I know Van Haywood and Linda Greenwell are big advocates of that way of whitening. They prefer to whiten the top arch first, get that done, and then do the lower. And the main reason behind that is top teeth tend to whiten slightly quicker, and there's less sensitivity with the top teeth, okay? That way, if you get those done and the patient's happy, they're going to try and they understand the result. And when it comes to lower being a little bit more zingy, a little bit more uncomfortable, they're more likely to persevere with that. So that's something just maybe to have a think about. Okay, so how long does it take? Well, most research will say up to 6 weeks. All right, most of the kits and the average is probably 2 weeks, 4 if you're doing upper and then lower. So for most people, that's enough. But it's not going to be enough for everyone. And again, you need to have that conversation with the patient before, from your examination, from your diagnosis, so that they're aware that actually I'm going to need more than this standard kit. I'm going to need extra whitening material so that I can go on for 1 month or 2 months or 3 months. So again, it's all part of the examination. Okay, I'm conscious that I'm rabbiting on a lot, so we'll speed up just a little bit for you. Okay, so bruxism, is that a contraindication? Well, for the short time, for most patients that are using it, then probably not. If you're doing a prolonged whitening, so tetracycline staining, then potentially it will be an issue because they may wear through the trays. Otherwise, it can often act a little bit like a habit breaker, and that ties in well with TMD. Again, we're not meant to do it on pregnant lactating ladies. There's no real proof that there'll be a problem, but again, it's just following safety lines. We don't want any issues with that. So. Contraindications, again, very sensitive teeth, okay? Any cracks or fractures we need to be aware of, all right? And if they've got a very heavily restored mouth, so if they've got lots of fillings, a combination of crowns and veneers with teeth in between, then whitening might not always be the best option. So just be aware and have that conversation with the patient. As you know, under 18-year-olds can be a problem. Hopefully that will change. Some people struggle with trays. And some people struggle with material. Now, I've mentioned gag reflex. I haven't had any patients suffer with this, but if you do have a patient who struggles, then this might not be the way forward. And the main one, again, is be aware of unrealistic expectations. So, advantages. It's simple for the patient to use, all right? There aren't many patients out there who won't understand how to do it. Providing you've shown them, you've been through it, it's fairly simple for them to do. It's very easy for us to monitor. It doesn't take very long, and it's very cost effective. All right. Now, again, we're going to talk at the end about hygiene therapists doing this treatment. Again, if you can get those to do the treatment for you, then it even frees up more of your chairside time. Normally painless, I'm not sure about that. I think some people will get sensitivity. It needs to be managed. It's cheap and it's convenient. The main disadvantage is if the patient doesn't wear the trays, it's not going to work, all right? And the colour change and the dependency will be based on the time that they wear the trays and whether they're loading the trays properly. Are they putting enough solution in? Are they putting too much in? So that's why demonstrating at the start is really, really important. If a patient is struggling with the whitening and they don't seem to be getting the results I'd anticipate, I'll often get them to bring the trays back and the gel, and I'll get them to show me how they load them. And then we can ascertain whether they're putting too much in or not enough. Okay, so we've talked about those. Okay, you can get some gingival irritation and some soft tissue irritation. That can be from the tray itself or from the solution. And that's especially common with the stronger solutions that you use. So if you guys in Dubai are maybe using, 18% hydrogen peroxide or 25% hydrogen peroxide, you're much more likely to get problems with the gingiva. So that's why I would tend not to use that. Okay, altered taste is mentioned, but it's not something I've come across particularly. Sensitivity is the big one. All right, the splodge effect, I'll mention that a little bit because I tend to mention the splodge effect when I fit my trays and at that point with the patient. Splodge effect is where your teeth don't whiten uniformly. They tend to whiten a little bit more in one area than the other, and the teeth look splodgy. Not particularly scientific definition, but that's what it tends to be called. And it tends to be where patients have got little cracks in the tooth. So the bleach will get into that area sooner and it whitens more in that area than it does elsewhere. It will generally catch up. All right, but again, if you spotted that, it's worth mentioning to the patient before, so you're allowing them to be aware of that as a potential outcome of the whitening. It will change as everything catches up. So how long does tooth whitening last? Your patients are likely to ask you. Now, there are some papers out there that will say as long as 10 years. Now, I'm not convinced it'll 10 years. I'd be happy to say 1 to 3 years. But often we'll discuss a maintenance program with the patient. All right, so we'll talk about top-ups every 6 months or every year, depending on their lifestyle. But it works well, it lasts well. And again, another case, again, this guy had a lot of recession. I was concerned when I first saw him that he was suffering from sensitivity issues. He said to me at the examination he has no problems eating or drinking anything hot or cold or sweet. So we went ahead and whitened and he had no problems at all. All right, whereas looking at him, I would have presumed he would have had some sensitivity, but in this case, he didn't. This is one of the cases that of a patient who came to me, and this guy came to see me about having veneers. He wanted veneers doing. So we talked about veneers, obviously. We talked about composites, about porcelains, and we talked about whitening. And the first thing to do was the whitening. Now, we had quite a nice result with the whitening. And actually, at the end of that, he said, you know what, they're not as bad as I thought. Now, obviously, from us as dentists, looking at those, we can see they're shortened, there's attrition, there's wear going on. So what we did for him after the whitening is just replace his fillings labially that he had and did a little bit of edge bonding, and he was more than happy. So again, we haven't done the veneers that we thought maybe excited about doing. You might well come back for that in the future, all right? But for me, again, we haven't picked the drill up particularly, we haven't done any proper destruction to those teeth. We've whitened and we've done some minimal intervention dentistry. Okay, let's talk very quickly about power bleaching. Higher concentrations are used. Now, that's what they used to use, 20, 25%. Obviously, nowadays we can't, so we're limited to 6% in the UK and Europe, more again in Dubai. And it's got an activating light. Now, for me, if I'm honest, I don't think the light does anything. It helps dehydrate the teeth, which will give an appearance of whitening, but it doesn't, for me, really do anything. And they've done split arch testings in the States where they've done half with and half without, and there really is no difference other than a dehydration. Obviously, there's much more involved with the isolation of the tooth, and it just, for me, it's a long surgical procedure. So again, that's fine if you've got the time or you've got a hygiene therapist to do that for you, but for me, it's not my go-to whitening. There are uses for it. So again, these are the promotional slides from Zoom. I'll let you have a little look through those. So they reckon 6 shades in an hour. That's probably true, but again, for me, a lot of that is dehydration, and you get a lot of bounce back, rebound, if you like, within the first 24, 48 hours. Okay, I'll just give you a demonstration of one of those. Okay, so shouldn't be used on pregnant ladies, again, we've said that before with the nighttime whitening. Again, it's just to be safe. All right. Patient intolerance and non-compliance. Now, I used to do Zoom, and Bright Smile was another one we used to do quite a long time ago. It does involve sitting still for quite a long time. It involves having a retractor in your mouth. It involves having a paint on dam place. So it's quite, a lot of stuff going on in the mouth. And some patients do struggle with that a little bit themselves. Patients who are taking any of these drugs, then again, you shouldn't really be doing Zoom or the power whitening, and that's due to photosensitive reactions. So don't ask me more than that, but just be aware of those medications. And if they're taking those, you shouldn't really be using the Zoom power one. Advantages, well, for me, are there any advantages? Is it quicker? Well, if you've got a patient who's maybe getting married at the weekend and they've suddenly decided they want something doing, then yes, I guess it has a place. But for me, it's not really quicker, because Zoom, that's nowadays the power whitening, they get the patient to wear the trays at night time afterwards anyway. So to me, it's the trays that are doing it. It might kick-start the whitening process, but it's certainly not going to do any better than using a tray system. Okay, it does have a wow factor, and some patients like the idea of it, and that's fine. I'm not saying don't do it, but when you're discussing it, just yourself be aware of the limitations and what you're actually getting out of it. Okay, so yes, it gives a wow factor, but is it actually any better than tray whitening? And I'd probably say no. Okay, so it's more expensive. I would guess so. I mean, I think there's some studies that say you have to have 2 or 3 sessions worth of this just to get anywhere close to what tray system will do. Soft tinge, I do know a colleague who didn't put the paint on dam everywhere and left a little bit of gingiva exposed, and they got quite a bad UV burn. So, you've got to be good at that. You've got to have, good operator skill. And then, as I said earlier, in the first 48 hours, you get a lot of regression, a lot of rebound of colour, which is why nowadays they tell you to wear the trays afterwards. So again, just be aware of that. I'm not saying don't do it, but just be aware of the limitations. So again, gingival irritation, we've talked about that, soft tissue irritation and sensitivity. You tend to find with this system, it tends to be one tooth that is like a zinger that you really know about, and you can paint some desensitizer on that as well. And dehydration, that's what this does. You're sitting with your mouth open for an hour. Okay, and you're heating the tooth up with the light. So a lot of the whitening is down to the dehydration. Okay, I'm just speeding up a little bit because we're nearly up to 50 minutes and we've got quite a long way to go. Okay, so let's talk briefly about the Enlighten evolution system. I like this system. It's a little bit more expensive, but it's the only one that I know on the market that guarantees a B1 result. I've got a lot of colleagues who use this, and everyone's very happy with it. Okay, so a simple case is basically 14 nights at home, and then you come in, apply a stronger solution into the tray, and you do that in surgery 2 times 20 minutes. All right. For a more difficult case, something you think is going to take longer with more persistent staining, you might well do 28 nights at home, and then come in and do 40 minutes on the end of that. Okay, so again, nice and straightforward, guaranteed B1 result. Okay. And this is where we'll talk a little bit more about trays. Okay, so again, these trays are Evolution 2 trays. I do very similar, but I get my own lab to do them. As you can see, they've scalloped around here, and I think that helps hold the bleaching. Whereas if you look at these, there's a lot more chance of them escaping. All right, so they tend to be more comfortable when they extend onto your gingiva, and I think it holds the whitening in better. Okay. Right, one thing that Enlighten will say is they're very confident that you'll get the canines the same colour as the other teeth. All right. Now, canines to me are a harder tooth to whiten, and that's because there's less actually enamel there, more dentine to whiten. They're a bigger tooth. Okay, and that's just that case again, which we looked at earlier. Okay, so non-vital tooth bleaching. All right, let's talk a little bit about that. As I said, it's been done in a lot more depth last week, so we're going to go through this, give you the main indications for it and the do's and do nots. But again, if you want further information, some videos on it, again, have a little look at Linda's lecture. So how many of us have a patient like this with potentially dark tooth? Okay, they come in and they've got that one tooth that's dark and they want it whiter. How do we do that? How many of us have got patients like that? All right, and it can be a real dilemma. All right, we don't particularly want to be crowning a tooth or veneering a tooth. We know that just veneering one tooth on its own amongst natural teeth is the hardest crown to get right. All right. It's much more difficult to get that one tooth than it's doing 2 or 4 or 6. So this can be a real dilemma. Okay, so the examination is really important. We must have a PA of the tooth. We must check apically. Has it been root filled? Has it not been root filled? What's the quality of the root filling like? Okay, so we need a good history. Is there a history of trauma or occlusal interferences? And this is where understanding a little bit more about the history of the patient is really important. Okay, so trauma can cause sort of calcific changes within the tooth, a sort of metamorphosis, if you like, of materials inside, and pulpal problems, necrosis, or maybe there's some pulp left in there, it can bleed into the tooth, and that can break down and you get ferrous sulfate staining the tooth. So try and work out what the cause is, and that'll be easier from your x-ray and your vitality testing, and then you're in a better position to treat the tooth. Okay. I tend to use 10% carbon peroxide. Again, it's my go-to for pretty much everything. I don't tend to use hydrogen peroxide much for this. Again, in theory, because you know, with the walk-in bleaching, we are going to be changing it, you could do, but again, I tend to stick with the 10% carbon peroxide. Now, I've mentioned endoperox here because it's something that I used to use when I was doing my master's and I was at university. We now no longer can. Okay, it's 100% carbon peroxide, which is about 30% hydrogen peroxide, so it's much stronger than we're allowed to use in the UK. But for you guys in Dubai, if it's available, it's something you may want to consider trying. It does work very well. Okay, so we have a walk-in bleach and an inside-outside bleaching. So let's look at the contraindications first. So if the root filling is poor, it's short, it's not well obturated. Okay, there's maybe an area present on the tooth and we can't compare whether that's getting larger or smaller. These are things we need to be aware of. Is there a draining sinus present? Is there any pain with the tooth? Is it TTP? Okay, all these little things we need to be bearing in mind because we don't want to do internal whitening on that tooth if it's going to cause more of a problem. Okay, so basically all we do is we place our carbamide peroxide within the tooth and seal it in, and that's for walk-in bleaching. It can be a little bit temperamental. It can work really well or not very well. And I think the reason it often doesn't work well is, as dentists, we haven't taken the GP down far enough. We need to go slightly below the CEJ and then build it with some resin modified GIC or some composite to stop it going down. That'll stop any resorption that we may have. Okay. When they used to talk about the fear of internal resorption, that was used to be when they used to put hydrogen peroxide and actually heat it. Now that's something I would definitely not advise you to do. Okay, so heat and hydrogen peroxide should be avoided at all costs, but we'll look at the placement and the preparation of the cavity in a moment. So what do we do? What's the technique? Well, we check a good root filling is in place. If it's not, and we're concerned, then we may have to do that root filling again before we do our whitening. Okay, we're going to clear the GP to just below the CEJ, 2 millimeters or so. It's quite handy to use a perio probe. You can put that against the tooth, look where you want to be, and then you can use that to measure within the tooth. Okay, and then we're going to cover the walls and the floor with a paste, and we seal it in with cotton wool, and then we review it every 3 to 5 days and repeat as necessary. And that's sealed into the tooth. All right, now this is, pardon the older diagram, it's the best I could get for you, but we've taken the GP down. All right, and we seal. Now in here they've used zinc phosphate. I wouldn't use that. I'd use a GIC or a composite. Okay, and the idea is the orientation of the tubules here is in a good position. As you get down, they start to do this, and that's where there's a scare of getting internal resorption. So providing you seal, Linda was interesting the other day. She was saying to do sort of a bobsleigh design. All right, so you run it up a little bit in the middle. We then place our bleaching agent, our cotton wool, and then our IRM. I tend to use GIC again. I just find it's easier. It's already out at that stage. And then when we're finished, we can place our glass ionomer and composite. We're going to talk about bonding in a minute, but we can wait a few moments, a couple of weeks, and then we can do composite if need be as well. So this is the endoperox. Again, can't use this now. It's 100% carbamide peroxide, so it's too strong for us to use in the UK. But for you guys in Dubai, that's what it looks like. And you mix the liquid with the paste. It's quite granular, and you place that into the tooth and seal it. It works really well. Now, this is a case back from 2008 now when I was doing my master's. This patient came in, obviously concerned. She's only a 23-year-old girl. She had root fillings done on those two or three times. The access cavities were huge. and the root canals are huge, although they did look well obturated and done properly this time. The problem was, initially she wanted veneers, but there wasn't really enough tooth left. The labial enamel was very thin and the interproximal enamel was very thin because of the size of the access cavity. So we treated this with a walk-in bleaching. We seal it in, and I did it 2 or 3 times, and this is the change. So it's a little bit brighter, this photograph. And this was done after 3 lots of walk-in bleaching and after we replaced the resin work. And this was straight after we'd taken off the rubber dam. Now, that was 2008. You know, things have changed. I believe I'm a better dentist now than I was then, and I'd want to put some more characterization into these. But I think, again, if you look at the change from there to there, it's done the patient service, a minimal intervention way of treating it. Okay. Inside-outside technique, I think this is a much better technique to use, and I think it's a bit more predictable, but you do need a patient with a little bit of dexterity, a little bit of understanding, so not everyone can do that. So it's been around for a long time, and the advantage of it is over the walk-in bleaching, which is sealed in, this one we're changing. You get the patient to change it. So I demonstrate it, we prepare the cavity like we did for the other one, but we leave the cavity open, and we get the patient to inject the bleach gel into the back of the tooth and into the tray, so it's bleaching the tooth from the inside and the outside, and I believe that has a much better result. All right. Now, it is very important when you're doing this, and I would stress this is really important, if you're whitening a darkened tooth, whiten that tooth first. Don't try and whiten everything at the same time, because what will happen is the other tooth will whiten lovely and beautiful, but the dark tooth probably won't whiten as well, and you can be left with an even worse discrepancy. So whiten the darkened tooth first, get it as good as you can, and then whiten the other teeth to match to that one. All right, you'll get a much better result. And one way to avoid whitening the other teeth initially is to use a cutaway technique. So here is the tooth we're whitening, and these teeth are cut away. So any bleach that comes onto these teeth is washed away. So you're not going to get a lot of whitening elsewhere. It will work predominantly on this tooth only. It does mean having a second tray, because when you come to whiten all the teeth, you'll need a separate tray, obviously with these in place. Okay, but really important to just whiten that tooth the best you can, and then whiten the other teeth to match to it. Okay, I'm going to go slightly quicker now because we're up to an hour and I've still got a few to go, so bear with me. I hope you're all right with me running over a little bit, and it just means we might not have as long for questions and answers, but we'll see how we go. Okay, so microabrasion, I'm sure you've heard of it. It's not actually tooth whitening, but I think it fits in very well to the tooth whitening process. And it's basically just where we remove a limited amount of the enamel. So if they've got little white spots or very brown spots on there, we can polish those out. And we use a hydrochloric acid, all right, and a brush with little bristles on that help rub that away. Okay, it's great for hypermineralization. Obviously, we don't always know how deep those discolorations go. So you have to try it and see to a certain extent. Some will work well, others will be deeper, and you might need to do further, more macro abrasion with a burr if need be. But this works really nicely. All right, so it's a little paste with hydrochloric acid, rub it down, and you polish it onto those teeth. Okay, and it removes those brown and white spots. Okay, it's only removing about 20 to 30 microns. All right, and it tends to do it once or twice depending on how often or how bad that staining is. If after 2 or 3 you've still got some staining left, then I think you're going to have to look at other alternatives to get rid of that. Okay, and that was a case I did recently. So again, you can see the brown staining on here. All right, and again, this is just after one application. So you can see the dryness of these teeth. All right, after we've taken the rubber dam off, we reviewed her again and we did some more whitening and we did some more microabrasion at the end, and she was very happy. So as soon as I get those photos, I can update that forward. Icon, so this is a resin infiltration technique. Again, it's not whitening, but it's a good adjunct to whitening. So those that have heard of it, I'm sure you're enjoying it. Again, it's limited to its cases, but on those cases that it works with, it's really good because it means we don't have to take our burr, we don't have to do anything else to the teeth. Okay, so these are all from these slides from DNG, so I must thank them for providing those, and it's their introduction to whitening. So this is a guy who'd had orthodontics. Obviously, with the brace, it's more difficult to keep clean. Now the brace is off, the patient is able to keep these clean, so these shouldn't progress too much. So Icon and whitening were used on this to try and remove those teeth, those stains on their teeth. I'll talk you through the technique very quickly. Obviously, if you want to do icon, then I'll suggest that you get, I think it's DMG in the UK that provide it. I'm not sure in Dubai, but they'll provide you with an ins and out and a PowerPoint exactly how to do it. And there's loads on YouTube about it as well. So we clean the teeth and we etch the teeth, hydrochloric acid this time, and we wash them. Okay. Now, once you've dried them, there's a stage where we actually use an alcohol. And that's for us to test, because if the alcohol soaks into those stains and removes them, then we know that applying the icon will work. If we put the alcohol on and it doesn't make a difference, then we can re-etch again and try it again. But if we keep doing that and we're not getting rid of the white spots, the brown spots, we know that the icon infiltrate won't work. So it's a bit of a test session to know how we are. So preview, we switch the lights off, and then we do our first infiltration. Okay, and this is the icon resin going into place. All right, excess needs to be removed off, because once you cure it, it's a bit like a bond, you get bits and flashes of it. So we need to clean off the surface, the excess, and we need to clean in between the teeth. And then we light cure for 40 seconds. Okay, and I think you'll agree, that's a pretty spectacular result. Okay, again, for me, potentially you could do a little bit more whitening, but as a change from one to the other, that's really good. Lots and lots of information about that. All right, that's the case by Richard Field. And again, if you look at the white spots on the central incisors and how they've gone on the right-hand side. Linda Greenwell has done a lot of papers on this. So again, have a look at her website. Bonding, okay. The main take-home thing about bonding is that we shouldn't do any bonding for at least 2 weeks after we finish the whitening. Okay, so I tend to get them back for a review, check the colour, and then I'll wait a minimum of 2 weeks before I do any composite additions, any incisal bonding, before I do any veneers or anything like that. I'll always wait 2 weeks. A, it allows the bond strength of the enamel to be back to normal, but secondly, the colour tends to have stabilised as well. All right, and as it says here, there can be up to a 25% reduction in the bond strength, so it's worth waiting the 2 weeks to get a better bond strength. Okay, sensitivity. So tooth sensitivity can be chemical, and that's usually the problem. It's a problem with the solution itself, okay? But it can also be from mechanical irritation from the tray. So try and work out what the problem is. Again, a lot of the treatment of sensitivity will come from your diagnosis and examination at the start of the procedure, okay? We know that the peroxidase penetrate the port within 15 minutes at the most, and you get a reversible pulpitis of sensitivity with that. And again, I mentioned this before, if the patient's got sensitive teeth to start with, they will suffer from sensitivity during the treatment. So be aware of that and start managing the sensitivity beforehand. Okay. So how do we manage the treatment and the sensitivity? Well, we can reduce the amount of wear. So maybe bleach every other night, or 1 night, 2 nights off, depending on the severity. All right, and we can reduce the concentration of bleach. So this is why I'm a big fan of using the lesser strength to start with. We know we'll get to the same endpoint. It might take a little bit longer possibly, but there's less sensitivity. All right, and then the active treatment is to the application of toothpaste and medicaments. All right, we can use the trays, in fact, to place the medicaments in so they seat on the teeth, and that works really well. So we've got fluoride, potassium nitrate, and arginine, they're the main ones, and different sensitive toothpastes have different combinations of different chemicals in them to work. Okay. So this is just a quick example. Tooth mousse works very well. The amorphous calcium phosphate is really good. That's within the Philips material itself. Polar do a soothe, which is a desensitizing gel that you paint on the teeth. So there's lots of different ways of managing it. But again, it's much better to warn the patient before, treat the patient before, rather than having it as an afterthought. Oh, we've got sensitivity, we need to do something with it. So planning ahead, know your patient and know the treatment. Okay, post-treatment instructions. Again, I don't have a big thing with this, but obviously if patients are keen for it to last, then explain to them what makes them stain again and get them to avoid those things, all right? So avoiding particularly stained foods, lots of black coffee, etc. To me, it's not a problem, because if they need to top up, they can just use a top-up gel and get them back to normal. Photography, really important. We said about having shades before and after. It's worth going on a photography course. It's nice to have the same size photograph. You know, you don't want one that's showing some teeth, the other that's showing hardly any. So we want a uniformity to our photographs. and that's really important. It's good to be able to take the photos you can see on the right and give them to the patient. Say, look, this is you before and this is you after. All right. It's something they'll show their neighbours. It's something they'll show their friends. And again, it brings patients into your practice. Again, this is the shade guide in value order from light to dark, and it's also got the OM1s, etc. on the left-hand side. So we're coming to the end. You'll be pleased to know I've gone over. So a couple more moments and we'll get some questions and answers for you. Documentation. Well, the way I did this is I used some of the information from Van Haywood and from Linda Greenwald, but what I also do is I try to sit down and think, what questions are my patients asking me about whitening? And those questions that have been asked over the past 20 odd years, I thought, well, let's put those into an information sheet. So our information sheet basically answers all the questions that we've been asked. So it's quite a nice way of doing it, and to give it to the patient so they can read that beforehand, and it's used for the consent process as well. So things like how long to wear the trays, what to do if they experience sensitivity, okay, explaining about the splodge effect. The other thing I always mention is any white spots in the teeth often stand out slightly more during the process, but then everything catches up and blends up at the end. So again, mention that before rather than ringing up or wanting an appointment, just to discuss it, saves you clinical time as well. Okay, how white will my teeth be after whitening? That's all. How well will it work? Well, it depends. Like Paul always says, it depends. So again, for me, I would always tend to under-promise and then hopefully over-deliver. If you've got someone who's young and got quite white teeth to start with, they will whiten, all right, but they probably won't whiten as be as dramatic effect as someone who's got quite dark teeth, all right? So tend to gauge that a little bit from the patient. The other interesting thing, and don't ask me why, is if you look at the colour of the patient's eye, the whiter their eyes are, they tend to be the whiter the teeth will go. And I picked that up from Linda back in the early 2000s at one of the World Aesthetic Congresses. So that actually has worked. If they've got quite darkish, yellowish whites to their eyes, the teeth won't whiten as well. So it's just something to bear in mind. Okay. Consent's really important, all right? And we always put, there's no guarantees with it, blah, blah, blah. And the important bit at the bottom is about the photographs, all right? So always, all my consent forms when I'm taking photographs, I have something in there so that I'm able to use them, either whether it's to show other patients. So it's good for you guys to have a book to show patients. It's always nice, I think, for you as a dentist to show your patient's work that you've done. This is what I've done. Yeah, this is my patient. These are my patients that I've treated, and I think that builds a lot of confidence in you. So have your own book of treatments, whether it's whitening, whether it's cosmetic work, whether it's just composite fillings. Take some photographs, build up a portfolio of your work. That's great as an associate, because when you're looking for jobs, it's hard as an associate now. Where do you go? What do you do? If you can turn up, I know if I was looking for an associate and they turn up with a portfolio of stuff they've done, then for me, they go straight up to the top. And then provided they can chat to patients and they're fairly amicable, they're in there. So portfolio is a good idea. I know some dentists give their patients a logbook to keep. It sort of gets them involved, some accountability. I don't tend to do this, but obviously in our records we have starting shade and stuff, but for them, they can monitor themselves and follow how long they've worn it, etc. It creates a little bit of accountability. Okay. And again, just to mention here, it is quite a good idea if you've got a patient who is umming and ahhing to possibly look at whitening the top teeth first. As we said, they tend to whiten quicker and they're less sensitive. So 2 weeks for the top and then getting the back review and 2 weeks for the bottom. It makes the treatment last longer, but I think you get a lot better patient compliance. A lot of my patients just want the whitening quick. So we do top and bottom together. So have the conversation with your patient and you get to know your patient and you can say, hang on, this might be a problem, this one. Let's look at doing the top first. Especially on those patients who maybe got slightly worn, erosion or attrition to the lowers, they're likely to be more sensitive. So getting the top ones done, it'll then give them the enthusiasm to do the lowers. Okay, finally, just to finish, hygienists, therapists, etc. and bleaching. They can do it now, providing as a dentist we give them the prescriptions to it, there's no reason they can't do it. And I think that's great because as a therapist and hygienist, it's great for them to have an expanded duty. It's great for them to be doing something different, okay? So again, they can do it, but they need to have enough information and prescription from the dentist to enable them to be confident in that it's been prescribed correctly. So what the staining is, what solutions we're going to use, how long we're going to do it for, etc., etc. Okay, so again, we need that description of the proposed treatment, a little bit about the discoloration and why it's there, any problems that we might have or concerns about the teeth written down, and then a follow-up maintenance. And this is the sort of thing we have to give to our hygienists and our therapists so that they're in a position to do the whitening for us. Okay, they need to show evidence of training. Okay, so they need to do lectures, something like this, I guess, go to seminars, live demonstration, then hands-on sessions. So I think it'd be a really good idea for them to do the background, learn a little bit about the procedure, then maybe watch the dentist do one, and then do one with the dentist supervision, and then they can start doing it themselves. That way, you've logged all your training, and you can keep an audit of the work that you've done. Okay, so in summary, it's safe, it's good. We should all be doing tooth whitening. It's one of those no stress ones if you've done your diagnosis properly first. All right. Ensure good patients, ensure you haven't got those patients with unrealistic expectations. But as I say, my big one is to under-promise and over-deliver, and ensure you've got really good clinical records. Okay, thank you. I've gone over a little bit, so I'm afraid we haven't got quite as long for questions, but we will do our best. I can probably spend 5 or 10 minutes going through questions. I'd like to thank you all for joining me. It's been great to have so many on board, and I hope it's been of use. If I don't get to any of the questions, then please feel free to email Lou, and then she can obviously forward them to me and I'll answer you. So thank you to those guys who have watched, and I'll see. Are you there, Lou? I'm going to stop sharing. I'm just working out how I do this. Just bear with me. Now there you are. Let's make you bigger. Okay, so we've got some questions in the Q&A section and some in chat. So we've got a lot. Let's have a little look. The first one is nice beard, Adam. Hope you're well. Well, thank you very much for that one. I'm very well, thank you very much. Let's go down to the next one. So the next question is, although bleaching is safe, we're using a mild acid. Is there a way, oh, hang on, where's that one gone now? Is there a way to qualify what the actual risk to the enamel is? Well, it's very mild. There's a slight increase in the pH, as we said. That actually has a therapeutic effect. And as far as quantifying it goes, there's lots of research. If you go to the Van Hayward website, they've done lots and lots on there, and that will lead you then on to other papers. And it's been shown, as I said in one of my previous slides, it does no damage to the enamel. All right, it does no damage to the dentine. It is safe to use, so please don't worry about that. Is 6% hydrogen peroxide limit for home kits the same for carbamide peroxide? And are there limits for in-office concentrations in the UK? So thank you, Mark, for that. So what they've said is in the UK, 6% hydrogen peroxide is the strongest solution we can use. Okay, so that's the maximum we can use for in-trays and power whitening and everything else. So if you look at, for example, for the Zoom power whitening or the Enlighten in surgery side, it's 6%, we cannot use longer. 6% hydrogen peroxide equates to about 16, 17% carbamide peroxide. So that's the trade-off between the two. So 10% or 16% carbamide peroxide you can use. I prefer the carbamide peroxide myself, as I've said, because it has a longer life and it makes it ideal for nighttime whitening where the salivary flow rates are less, etc. It just works really well. Do you use desensitizing products during the treatment phase or before? Sorry, Anitha, thank you for your question. So do you use desensitizing products during the treatment phase or before to inhibit the permeability of the peroxide at all? Again, I gauge this on the amount of sensitivity that the patient's having. If I know that they've got a lot of sensitivity, I will treat them before with the solutions, whether it's in tray or toothpaste, and I don't have a problem with that. They still seem to whiten absolutely fine with that. Okay, so yeah, don't worry, just do it. It's all about planning. It's managing the patient's expectations and it's managing the patient's sensitivity. So if they're bad and you're concerned, start treating the sensitivity early. So you've seen them for an impression, you've had a chat, they want to go ahead, you've done the impression, you know they've got sensitivity, so start them on the sensitive toothpaste. See how they go when they come for the fit, and then might withhold the tooth whitening product and send them home with the tray so they can start applying them as a medicament over the teeth and then do the whitening. So it all depends on the amount of sensitivity that the patient's got. Effects on fluorosis of teeth. Thank you, Manroop. Yes, the fluorosis, we talked a little bit about the white spots sometimes. They can sometimes stand out more whilst you're doing the whitening. but they often blend out. If you imagine someone with a white spot on the tooth, it's quite obvious, and that's because the background, the tooth, the colour behind it is darker, so it's more obvious. If you whiten the background, then the white spot doesn't show as much. All right, so I have no issue with that. Obviously, you may, depending on the extent, be looking at some more microabrasion or possibly macroabrasion, depending on the state. So each case in its own merits. Okay, so another one from Anith, thank you. Is there a way to whiten just the necks of the teeth after the splodge effect? The splodge effect is not something really to worry about. The splodge effect happens because it's where the bleach gets to first and the quickest, and it whitens more, so it looks whiter than the rest of the tooth. Over your 10-day, 14-day period, the rest of the tooth will whiten and the splodge effect goes. So it's not something you end up with. You don't end up with the splodge effect on that tooth. Hope that helps. What's the recommended time protocol for in-office for the passers? I'm usually doing 3 times 50 minutes. Any thoughts or evidence suggests? No, Mark, that's fine. Obviously, just follow the combination of whether it's Zoom or the other in-surgery ones they're using. Ask them what they use and follow theirs. For me, I don't think there's a huge benefit to it, to be honest. I think with Enlighten it works quite well, and the reason being they say that it's cleaned up the teeth, it's opened the dental tube, so it permeates better in surgery. But no, that's fine what you said. How do you ask your labs to create the seal around the gingival margins? For a scalloped gingival margin, is that what you meant? No. So my trade design, and again, everyone's different. The researchers said there's very little difference between them, so it's just personal preference more than anything. I would tend to ask them to actually score, so just run a knife or an instrument around the neck of the tooth to get a little bit of an undercut, so that when sucked down in, the suck down material is put on, it sucks into those areas and forms like a little seal. The scalloped and non-scalloped is more to do with how far it moves onto the gingiva. So for me, I think if you have your tray shaped like your teeth, so it's following the shape of that scalloped, I tend to find it's a little bit more uncomfortable and less tolerated by the patients. So running the material up onto the gingiva by a couple of millimeters tends to make it more tolerable, which is what I do. Thank you, Yenu. For microabrasion, I use Opaluster from Optident, and that's the only one I've really come across and used. So for microabrasion, as I say, from Optident, Opaluster. How do you determine the saturation point? Well, you don't really know till you get there, and that's the problem. Everyone will have a slightly different end point. So it's one of those cases where you've done your whitening, and I think, again, using the whites of the eyes can sometimes help. If you think there's a bit more in it, then go for a bit longer. So take a shade and say, look, we'll give it another 2 or 3 days. If you're still seeing a bit of an increase in whitening, carry on. If you're not, then that is the saturation point. Thank you, Sharam and Nicholas, saying for a great presentation. I'm pleased you enjoyed it. What's your view about the effect of heat? Okay, so what is your view about the effect of heat on increasing the rate of diffusion of hydrogen peroxide, and how do you achieve this? Well, I don't. Simple as, I wouldn't do that. I can't see any benefit at all for doing it. And there has been some research to say that it's in cases like that where you're heating hydrogen peroxide that you stand more risk of getting internal and external resorption. So my answer to that is don't. I can't see the point of doing that. Okay, so next, Lenovo. I'm all right for time, by the way, Louise?
Yeah, you're fine.
Okay, so Lenovo. So root canal tooth with apical radiolucent lesion or initial apical resorption. Shall we retreat and then white the tooth at the same time? Well, no, I wouldn't do both at the same time. I think if you take a PA and there's an apical area, you need to do the root filling, without a doubt. I would then leave it a couple of weeks, 3 weeks, whatever, to make sure there's no problems with that, and then do my whitening. If there's a root filling in place, but maybe it's not particularly well condensed, but there's no apical area, then I would still probably want to redo the root filling, if I'm honest, make sure it's properly well obturated. So no, I would tend to do the whitening after. The problem if you try and do both at the same time, you don't really know which is causing a problem if there is a problem. So get one done, sort that out, and then do your whitening. Boutique whitening kits, absolutely fine. Most of them, they do a 10% and 16% carbon peroxide. I think they're nicely put together. I think the kits look nice. I think it has that nice promo stuff, put your logo on it. I'd have no problems at all with that. It's fine. Just reading one from Yanu about children. Teeth. Okay, so she's asking really about whitening pediatric cases. And yes, you're right about psychological development. And this is where the age limit, I think, in the UK and Europe is too high. I think we should be able to do younger children because it can have a psychological effect on some children. You know, it's like everything else with stress. It can just be that extra nail in the coffin. They might be stressed. They might have a poor time at home. They might, you know, be underprivileged. And then on top of that, they've got whitening. And it's just something else for them to get stressed about. If they're getting bullied at school, then yeah, as far as I'm concerned, we should be looking at whitening those teeth. Again, questions about handling sensitivity during and post-bleaching. Well, again, hopefully you've assessed them before so you can start that treatment. We mentioned in passing about the fact that if they've got sensitivity and it's down to the solution, I would tell my patients maybe to have a night off, so bleach alternate nights. If I've given them 16%, I might reduce to 10%. Again, I always start with 10% because I think it's better. There are 5% solutions on the market you can get now, so you can get less strength. The thing is, we know we'll get to the same endpoint. It'll just take longer, so it's managing those patients. Freddie, hello, Freddie. Freddie's one of our associates, so big hello to you, mate. Restorative treatment plan and patient has active caries. Can whitening be commenced prior to restorations, or should established stabilisation be completed first? Okay, so that's a really good question, Freddie. So what Freddie's asking is, if the patient's with you who wants whitening, but they've got some caries or deficient lesions, would you fill them and then whiten, or would you whiten and fill? Well, I would want to stabilise the patient. So if that means maybe putting some resin-modified glass enema in, whether it's around the necks or in a cavity, I would do that first. I mean, some of the resin-modified now are quite nice colours, so they blend in quite nicely. I would then do the whitening. All right, but I've told the patient that when we whiten the teeth, it won't whiten the fillings, so they'll need those redoing properly. So I would start with, you know, something like GIC, which is easy and quick to place, with a view that once we've done the whitening, we'll go back to that patient, and that's when we change to composite. But remember what I said about leaving at least 2 weeks between doing that. Okay. Would you use the same 16 that you use with your twist? Yes, so one of the questions for Sharon here is, would I use the same carbamide peroxide paste that I use in trays as I would do in my walk-in bleaching? Yes, absolutely. It's just a carbamide peroxide, not a problem with that. So again, we've had the same question from Lenovo about RCT. I would do my root canal, wait, and then do my whitening. I have a young patient, 15, who has trauma when she was younger and has an upper central root treated. The teeth has recently turned a bit darker. The RC looks great. And would you do internal bleaching at this age? So again, Sarah, where are you? If you're in the UK, then unfortunately at this stage, we're not meant to use internal whitening on under 18-year-olds. Now, if it's really obvious and it's causing her, you know, problems psychologically or whatever, then the only thing I suggest is maybe get in touch with your dental protection society and ask and say, explain the situation, say, look, she's 16, I know I can't do it till 18, but she's really getting problems at school with this, I'd like to do it. And then I think most of the time they'll okay that, but I would check. Okay, personally, I wouldn't have a problem with it. I don't think it would do any issues, but again, from a legal point of view, if you do it under 18, you are breaking the law. What is your opinion about Zoom and non-light method like opalescence? I think from the research that I've read and what I do in practice myself is tray system works, all right? The whitening is, the light systems and the power whitening is really just more of a wow factor and a kickstart to it. So I'm happy just using tray systems. Thank you, Hannah, for your kind words. So that's all the questions done. There are some chats now. I don't know how we do these. A lot. Thank you for that. So just some thanks for the webinar. That's great. Any questions? So again, I've had a question from Amber about when would tooth whitening not be suitable for a patient? What are the contraindications? Well, not to be too rude, if you get a chance to watch this webinar again, I went through a list of the contraindications. So increased sensitivity, lots of restorations in the tooth, all right, pregnancy, lactating, etc. So they're all in the webinar, so please take a look. What we got now, better now. Sorry, this is one for you, Louise, actually. Rafa's asking if there's a way to get previous webinars. That's something, if you email Louise at Tipton, she'll be able to sort that out for you. What's this? Trying to have a look now. I think we've covered all these. Okay, thank you. No, that's it. I think Freddie's already answered that one. Lovely. The rest of, I think I've been through. Thank you for your kind words, guys. I hope you've enjoyed it. As I say, webinars isn't really my thing. I prefer face-to-face teaching, and those that know me, who've done the tips and training courses with me, know that I love that face-to-face, that one-to-one contact, that chit-chat. I find you get a lot more out of that than you do from a webinar. So for those of you who do want to do more, and I think being in lockdown has made us realise that dentistry is going to be very different in the weeks and months to come. So I don't know what's going to happen with the NHS. I'm fortunate in a way I don't do much NHS. So I think for private practitioners who can get up and running, we should be all right. NHS, I don't know what will happen. And I think there's a big tendency we've seen from the uptake of the webinars that dentists want to learn new skills. They want to be better at what they do. So I can only stress you guys, if you've got the time, come and join us in Dubai, come and join us in the UK, Manchester, London. We run restorative courses, operative courses, aesthetic courses, and also keep an eye out for BARD. We were meant to have a conference. In fact, it was meant to be last weekend, and we've had to cancel it because of the COVID. So keep your eyes out. We'll be looking to host another one of those next year. So go to the BARD website, sign up, have a look at the TTL website and sign up. And just before I go, I'd like to thank Louise, Les, Paul and the others at Tips and Training for giving me the opportunity to talk to you. Thank you very much.